Hi everyone, my name is Tatiana Lyons and I'm going to be doing my project on euthanasia and physician-assisted deaths. So I want to bring up the Childress and Beauchamp's principles of biomedical ethics. As physicians, we take an oath called the Hippocratic Oath that has an overarching goal of do no harm to the patient. So in order to uphold these four principles help us to keep them in mind as we go about our practice. So the first one is autonomy. This is just allowing a patient who's fully competent, fully informed, to make a medical decision for themselves. Beneficence is the obligation of a physician to do what's best for the patient's interests rather than just what the doctor prefers to do. Non-maleficence is just to overall do no harm. And then justice is to carry out a fair distribution of care and equity amongst all their patients. So let's look at the difference between euthanasia and physician-assisted death or suicide. Euthanasia is, they're both painless, but it is the killing or allowing the death of a patient. So voluntary euthanasia has active and passive euthanasia. Active involves prescribing a prescription to the patient and carrying out these deaths in a hospital setting. And then passive euthanasia is allowing the deaths naturally by removing any life-sustaining treatment or like consistently prescribing prescriptions or anything like that. Involuntary euthanasia, which has a very negative effect, especially in other countries where euthanasia is fully legal. This is when the patient is, I guess, killed by the physician without their consent. So this often happens with incompetent patients who have been in an accident, and the physician has just decided to carry on with what the treatment is that they want to do. So the difference is physician-assisted death, same thing, except for the process isn't carried out by the physician necessarily. The physician will prescribe the medication, but most of the time these patients will take that medication home and carry out the process at home by taking the medication on their own or taking whatever it is was prescribed to them. So, as we look at the history of euthanasia and physician-assisted suicide, the first ever recorded instance was with Jack Kevorkian in the 1990s. He had assisted in a secret practice of physician-assisted death where it resulted in 150 patients dying. He lost his license but was not prosecuted until he proceeded with active euthanasia that by request of a patient. In 1997, Oregon was the first state to pass the Death with Dignity law, and this allows physician-assisted deaths to occur given that the patient had met certain requirements. So they had to be terminally ill with less than 6 months to live, fully competent, and not in a depressive state, which would be carried out with a psychiatric eval. And then they would have to have made two requests 15 days apart, along with a written request that had a witness present to attest for the request. Since then, there have been a couple states that have looked to legalize physician-assisted death, but overall there have been a lot of laws that tried to prohibit PAS, but nothing stuck. As of right now, euthanasia still remains completely illegal in all 50 states. So when we look at the patients and who generally receives these prescriptions, who asks for them, and why they do it, we see that in this graph, the majority of the terminally ill patients that do ask for the prescription have cancer. So it kind of dies off after that to many different things, but these are the people who seem to look for that as a solution more so than just palliative care. So of this population of terminally ill patients, the average is around 65 to 84 years old, with the average age being 75. Majority of these patients will receive the prescription and continue this process at home, and they had been previously enrolled into hospice. In 2022, there were over 3,700 people who asked for these prescriptions, but only 24 actually fall through with it. So this just shows that a lot of people that do ask for it end up not completing it for many reasons. But when we look at why people do choose to carry out with it, we see that a lot of patients have prior societal and familial issues. They either just lost their job, they have a lot of financial burdens due to medical bills or things prior, and they just lose their feeling of belonging to the world and their place in the world. They also begin to feel like they're a burden to their family, emotionally, financially. They've lost hope in lessening their pain or recovering, and they just had an overall decrease in their quality of life. And overall, they lean to this once they realize that their palliative care is really not relieving their pain how it should. So when we look at the research and the numbers of who is for and who is against it, a lot of times it's split 50-50, but this ultimately changes based on the verbiage that the patient is receiving their questions and what they're currently going through within their life. So for those who are for euthanasia, they advocate by saying that it increases a patient's autonomy. They believe, obviously, like we say, a competent informed patient is allowed to make medical decisions. Therefore, if they are choosing to discontinue their treatment, they should also be allowed to do that. It would also minimize patient suffering. If palliative care isn't successful, they believe they should be given that option once it has been declared that their palliative care isn't successful. It would also reduce advanced directive abuse. If this patient has an incurable disease and has become incapacitated due to some type of disease or injury, having this written prior to that would help to remove the decision from the physician, the parents, a spouse, family, all of that. Those who are against it actually counter what those who are for it with in regards to the patient autonomy. They believe that it would cause the patient to feel obligated to take this option because they don't want to be a burden to their family, or they don't want to just be this person in society that is using up all of these medical resources. And then it also just leads them to feel like they should be scared of all their pain and suffering, and that the only way out is death, rather than look towards different palliative care. Another reason would be, as physicians, we are here to promote hope to patients, promote a bunch of options to either manage their pain or fully remove it, and euthanasia just counters that. It encourages hopelessness, gives them a way out of it without having to live, and then it also ultimately goes against the Hippocratic Oath of doing no harm. The last thing that people against this would say is that it removes all protection from the weak and vulnerable. So because guidelines aren't consistently followed right now, especially in other countries, it becomes very difficult to regulate, and anybody with a terminally ill disease or mental illness could have this option if it's not regulated. And this is ultimately how involuntary euthanasia begins, because physicians are then having a lot more of the decision in it than the patient. When we look to see why it is important, I want to point out this graph over here. And Netherlands, Belgium, and Canada all have legalized euthanasia. And we can see that those numbers are extremely large in comparison to in the United States. And the dark blue represents 2021. Canada has the most, having over 6,000 patients carry out PAS. So obviously legalizing it would influence the use of it, and I think that would just promote a negative perspective on terminally ill patients and mental health patients, and it would lessen their likeliness to look at palliative care and natural treatments and all of that other stuff, and it would make them turn to PAS a lot faster. Another thing that I'd like to point out is that mental health is exponentially growing in the United States. And as we saw on the last slide, as to why patients choose to do PAS at some point, a lot of it is because of their mental health and how they feel that they would be a burden to other people, or how they see that other people would view them. So it would just contribute to the amount of patients that choose to end their life. And then the last point I'd want to make is this is a slippery slope effect. First, it starts off with the terminally ill patients, but some patients are terminally ill at 12. And there are a lot of things that happen in this world, a lot of miracles that happen medically, where these patients who have these diseases that seem to be incurable have come out of it. So it's just, there's no line that can be drawn at this point. It's not regulated. So it just needs to, I just think it isn't worth legalizing, at least not yet. So as future physicians, we can look to prevent this in some way by offering better affordable health care, regular health care and mental health. One thing I noticed in the research that I had done is that patients expressed how easy to treat patients had better access to health care that were more affordable than harder cases, just because some physicians don't seem to want to bother with the harder cases that may not be fixable. Another thing is people also ask for holistic healthcare environments that are tailor made to them, that have options of continuing after they have recovered, and then just a better shared decision making with the physician patient relationship. And then at the end of the day, improved end of life care would help. Improving palliative care, improving methods of palliative care would just give patients more options rather than just looking to end their life on their own terms. And here are my references. Thank you.